Sorry about that. Okay. So we look at tumors of the small intestine as in these categories, because they are tumor-like conditions, often known as polyps, and we look at that, and they are both non-neoplastic and neoplastic polyps. Then we look at tumors or epithelial tumors, then mesenchymal lesions, and lymphomas. So in general, these are just sort of general statements. Epithelial tumors are a major cause of morbidity and mortality worldwide. And the colorectal carcinoma is the commonest in the GI segment. If you are not talking, can you mute so we don't hear all the sneezes and your background noise, please? So the GI tract is the host to more primary tumors than any other system in the body, not any other tumor, any other system. Sorry for that. And as you probably know from our epidemiology of cancer lecture, that colorectal carcinoma or colonic carcinoma is second to bronchogenic carcinoma as a cause of death in the US. Here it's much less common, but still an important cause of death or cancer death. And in the colorectal, adenocarcinomas or malignant tumors of the epithelium or mucosa represent about 70% of all malignancies of the GI tract. Then the mesenchymal tumors, lymphomas account for the rest. Benign tumors in general are primarily epithelial and are present in about 25 to 50% of older adults. So it's a frequent finding during colonoscopy, and not just colonoscopy, but even at autopsy. So some of them are incidental findings. So let's look at some terminology. The polyp is described or defined as a mucosal growth that protrudes into the lumen of the gut, and it could be sessile or broad-based without a stalk or pedunculated. So when a polyp is pedunculated, then it means it has a stalk, okay? And then it protrudes like a mushroom into the lumen arising from the mucosa, result of abnormal mucosal maturation, as a result of inflammation, as we saw, I think, when we had a lecture on inflammatory bowel disease, or as an epithelial proliferation with dysplasia, so as part of a neoplastic process. Then, of course, in this pictorial depiction, you see examples of polyps, so a hypoplastic polyps, so proliferation of the mucosa, often without dysplasia. Then, of course, there is adenoma, and then there is the adenomas can be pedunculated polyps with a stalk like a mushroom or sessile. when they are broad-based without a stalk. So sometimes it's not always polyps, but they could be polypoid or polyp-like lesions, common in inflammatory conditions such as inflammatory bowel disease, Crohn's disease, and ulcerative colitis. Hamatomas or tumors arising from the submucosa or muscular coat, but also protruding into the lumen. And when you have many polyps, then we refer to the condition as polyposis. Polyposis syndromes can be hereditary. They're characterized by the presence of multiple pedunculated or sessile tumors of the mucosa, such as familial polyposis coli. Okay. So how do we classify then tumors of the small and large bowel? Basically, we look at non-neoplastic polyps, and I've already given you some examples, like hypoplastic polyps, Hamatomatas polyps, such as Juvenile and Pearce-Jaeger syndromes, inflammatory polyps, lymphoid polyps, which are formed by proliferation or hyperplasia of the submucosal lymphoid tissue, and then protrudes into the lumen to form a lymphoid polyp. And then there are the non-neoplastic or epithelial polyps. If they are benign, then we refer to them as adenomas. And of course, they can be malignant. And some examples are just the good old colorectal carcinomas, for example, carcinoid tumors, both benign and malignant, anal zone carcinomas, just for example. Then mesenchymal lesions, the most important one for our purposes is the GI stromal tumors or GIST, and then others, really a mixed bag of others like lipomas, neuromas, angiomas, Kaposi's sarcoma, as can occur anywhere else in the body. And then the malignant lymphoid tumors or lymphomas can also present as in the gut. So let's look at intestinal non-neoplastic polyps. This represents about 90% of all epithelial polyps found in the large intestine. They are found in more than half of all persons over the age of 60 or older. So, and that's why I was saying it's often an incidental finding in one out of every 2 individuals during colonoscopy or at autopsy. The types can be hypoplastic, Hamatomatas polyps, inflammatory polyps, and lymphoid polyps. The hypoplastic polyp is often asymptomatic. More than 50% of them are located in the rectosigmoid colon and 20% in the ascending colon. They are often smooth and moist, round, small polyps, rarely larger than half a centimeter in diameter, and majority are sessile, meaning they don't have a stalk, because if they had a stalk, then they would be pedunculated. Multiple polyps are often frequent. You can imagine if there is an underlying condition to induce hyperplasia, then it will affect a large surface of the mucosa of the gut. They are composed of well-formed glands and crypts lined by differentiated goblet or absorptive cells. And when they are pure hypoplastic polyps, they have no malignant potential. Okay, and that's why it's important to, when a polyp is seen under during colonoscopy, that it be biopsied, because the malignant potential needs to be excluded. So larger hypoplastic polyps often have foci of adenomatous change or neoplastic change. And again, this is why it's important that all polyps, if they are present, that they should be biopsy, even if they look benign to the naked eye during colposcopy. So this is one hypoplastic polyp. It has a stalk rather than sessile, okay? And it has this fibrovascular cores, and it has very well differentiated goblet cells. This is another one, just at higher power to show goblet cells as well as absorptive cells. You can see how uniform they are. Then the Hamatomatas polyps, I'm hoping that you remember the definition of a polyp, which is really a developmental malformation of tissues that are found in that site, okay? So they're not tissues from elsewhere, okay? So developmental malformation, no malignant potential. Commonly seen in children under the age of 5 years in the rectum. And when it's seen in children in the rectum, we refer to it as a juvenile polyp. In the adult, then even if it looks the same, we call it a retention polyp. Often they present with painless rectal bleeding after defecation, or the mother may notice a polypoid lesion after defecation in the child. And of course, it can be very alarming. They may be large, rounded, smooth lesions with a stalk. So they are often pedunculated. But histology shows that it's composed of dilated tubules that are filled with mucus and lined by normal or inflamed cells, and the surface may be ulcerated. Juvenile Polyposis Syndrome, on the other hand, is the occurrence of multiple Hamatomatas polyps throughout the GI tract. Okay, so such syndromes as Peutz-Jeghers syndrome, which is Hamatomatas polyp. Okay, so we look at Peutz-Jeghers syndrome as an example of Hamatomatas polyps. Uncommon condition accompanied by mucosal and cutaneous pigmentation around the lips, oral mucosa, the face, and genitalia. It's a rare syndrome, autosomal dominant, mode of inheritance, and it's caused by germline mutation in the LKB1 gene, which encodes the serine threonine kinase enzyme. The polyps tend to be large and pedunculated and may occur anywhere in the GI tract, so not just in the small or large bowel. And they have an increased risk, these patients have an increased risk of developing carcinoma in other areas, the pancreas, breast, lung, ovary, and the uterus, okay? And that's why it's called a syndrome, okay? So here is a Hamatomatas polyp. It's nicely rounded and shiny and smooth, okay? And when you look at the histological section, you have fairly uniform crypts, no atypia, unless, of course, there is malignant transformation. Inflammatory polyps, the other example of non-neoplastic polyps. And as we said earlier, they occur in patients with long-standing inflammatory bowel disease, especially chronic ulcerative colitis. They may be multiple and represent an exuberant reparative process in response to long-standing mucosal injury. So they are really referred to as pseudopolyps rather than true polyps, okay? And here you can see that there is diffuse chronic active inflammatory process going on, okay? A lot of edema, so the mucosa sort of pops out because of the regeneration of as part of healing in inflammatory bowel disease. Lymphoid polyps, so you have submucosal lymphoid follicles that are hyperplastic, and then they pop out into the lumen, and this is what they would look like. Okay, so the bulk, really, the body of the polyp is this lymphoid follicles, active hyperplastic lymphoid follicles. So let's look at now at the neoplastic polyps or adenomas. They're generally grouped into two, tubular and vellus adenomas. And together, they occur mainly in the large bowel, less commonly in other parts of the GI tract. So the prevalence is about 20 to 30% before the age of 40. Increases to 50% after the age of 60. Male to female ratio is about the same. And these polyps can be either sporadic or familial. They vary from small pedunculated lesions to large sessile masses. And there is epithelial proliferation. And when there is dysplasia, there is loss of basal orientation of the nuclei. So the nuclei appear pseudostratified. And as I said, they can be divided into two tubular adenomas, actually three when you talk about the mixed type. Tubular adenomas, which have less than 25% vellus architecture. The vellus adenomas, which have more than 50% vellus architecture or long finger-like projections. And the mixed type, the tubulovellus adenomas that have about 25% and more than 50% of vellus architecture. I think I have some pictures I'll show you. So all adenomatous lesions arise from as a result of the epithelial proliferation and dysplasia, which may range from mild to severe as to represent transformation to carcinoma. So mild, no dysplasia, and all the way to carcinoma in situ, basically. So tubular adenomas are the most common, representing about 75% of all neoplastic polyps. They occur sporadically and also in well-defined hereditary syndromes. The average age is about 60, so it's really a disease of older adults. 75% occur in the distal colon and the rectum, and more than 50% occur singly, so they are single lesions. So at colonoscopy, the colonoscopist has really to be careful and not miss them, because they can be very small, a few millimeters, and of course up to large lesions, a few centimeters, and be pedunculated. So the stalk or the pedicle, it has a central core of fibrovascular tissue, and then that is covered with dysplastic colonic mucosa. And if there is severe dysplasia, then of course we are looking at the potential for malignancy. So here is a tubular adenoma. Okay, this one looks kind of sessile, doesn't seem to have much of a stalk. But this one in this photomicrograph has a long pedicle or stalk, and then the surface is lined by a mucosa that has lots of tubules or tubula. Okay, and in this on the right, in photomicrograph B, then you can see that the top and down the right side and down the left side, there's good basal nuclei. But in the middle of this crypt, you can see that there is pseudostratification of the nuclei and probably a few mitosis as well. So there is dysplasia in this polyp. The vellus adenoma is the least common. but largest and most ominous of epithelial polyps, because they tend to have a higher risk for malignancy than the tubular adenomas. And the age range is the same as the tubular adenomas, over 60. 60 to 65 is the peak age range. Similar male to female ratio. And often the common presentation is rectal bleeding or anemia from long-standing blood loss. It could be occult blood loss, so the patient may not necessarily notice that they are bleeding, or it could be an overt rectal bleeding. Large ones, large tumors may secrete copious amount of mucoid material that is rich in protein. And as with the tubular adenomas, they're most common in the colorectal area. So the rectosigmoid is the commonest area where 75% of villus adenomas occur. And here are photomicrographs showing you the long finger-like of villus projections of this sessile villus adenoma. And so they don't have a stalk like we saw in the previous one of the tubular adenoma. Excuse me. And looking closely at high power of the mucosa on the right-hand side, you can see all the nuclei are nice and basal and uniform. But on the left, there is a pseudostratification, elongation of the nuclei, and they are kind of crowded. So there is an element of atypia. So they range from 1 to 10 centimeters. So they tend to be so. Generally, if you have a large polyp, most likely it's a villus adenoma rather than a tubular. Okay, most are broad and sessile, like in this example. Okay, it doesn't have a stalk. They have a velvety appearance, projecting 1 to 2 centimeters into the lumen. And then you see these long finger-like or frond-like papillary projections with a delicate fibrovascular core if they are pedunculated. And for the villus adenomas, the degree of dysplasia to frank carcinoma is up to 40%. So that's why they are an important lesion because of the malignant potential. 40% will have dysplasia all the way to frank invasive carcinoma. So it's a polyp that we take very seriously. So then there is the mixed type, both tubular and villus components are present. These tend to be intermediate in size, frequency of having a stalk, degree of dysplasia, and malignant potential lies between the tubular and villus. So it behaves like half and half of each of these other varieties. So clinical features of neoplastic polyps. The smaller adenomas are usually asymptomatic, but they may present with occult bleeding. So if somebody is screened for occult blood, then it is positive and raises a red flag. The villus adenomas, which are much larger, are much more frequently symptomatic because of overt or occult rectal bleeding, or the copious amount of mucus that may be associated with these tumors. And they may produce hypoproteinemia or hypokalemia. The adenomas in the immediate vicinity of the ampulla ovata may also cause biliary obstruction, though its attendant clinical presentation. So what's the relationship between neoplastic polyps and carcinoma? This is, I think, an important question to understand or concept. Excuse me. So the adenoma carcinoma sequence is well documented by several observations as well as genetic alterations. The probability of carcinoma occurring in a neoplastic polyp is related to a few things. One is the size of the polyp, and we've already seen that villus polyps that tend to be larger have a higher risk of malignant potential or malignant transformation. The relative proportion of its villus features, so the more villus features it has, the higher the risk of malignant transformation, and then the presence of significant cytologic atypia or dysplasia in the neoplastic cells. And I've already shown you some of the features: the pseudostratification, the nuclear pleomorphism, appearance of mitosis, particularly abnormal mitosis. All these herald the risk of malignant transformation or the probability of carcinoma occurring in a neoplastic polyp. So we mentioned familial polyposis syndrome, where you have multiple polyps, and that runs in families. So genetic tendencies to develop polyps, and it's often autosomal dominant. So in essence, if you have the gene, the polyposis, familial polyposis coli gene, then chances are that you will have, it will be passed on even when it's present as in one of the autosomal genes. So the genetic defect is found in chromosome 5, the long arm of the first, I think the second band of the first region. I think you read it from left to right. And these individuals tend to have innumerable neoplastic polyps in the colon, 500 to up to 2,500 polyps. They are also found elsewhere in the GI tract, and most of them are tubular adenomas. And they have the risk of colorectal cancer in about 100% by the time they are midlife. For the Gardner syndrome, they have also polyposis coli, multiple osteomas as well, numerous skin epidermal cysts, as well as fibromatosis. So that's Gardner syndrome. Tubular syndrome, they have polyposis coli, gliomas, and fibromatosis. So these are the three syndromes that are associated with multiple colorectal polyps or polyps in the GI tract. Remember, they can be anywhere in the GI tract. This is a photograph showing the numerous polyps. This one must be in their thousands or hundreds, some small, very tiny, some larger ones, and it's the larger ones that are likely to undergo malignant transformation. Because remember, the larger ones are the ones that are likely to have villus structures. So malignant tumors of the large intestine. Let's look now at overt malignancies. The adenocarcinomas, I think we've already mentioned this in my introductory remarks, that adenocarcinomas or glandular tumors, malignant glandular tumors, constitute 98% of all cancers of the large intestine. Worldwide distribution, so they're found everywhere in the world, but highest incidence is in the West. Causes 15% of all cancer-related deaths in the US, and the mortality rate and incidence is higher in Black American in the US. The peak incidence is in the 6th to 7th decade. I don't know why I didn't put Kenyan figures, but What you can do is look up the Globocan figures for our top 10 cancers. I think at some point I will show that graph, even if it's not today. Predisposing factors, we've already seen some of them: inflammatory bowel disease and polyposis syndromes, particularly where you have tumors that have villus architecture. Male to female ratio, 2:1, so more common in males than females for rectal carcinoma, roughly equal in the colon, and males are affected about 20% more often than females. Diet does appear to play a role in the risk for colorectal cancer. So a diet that is low, has a low content of unabsorbable vegetable fiber, increases risk. High content of refined carbohydrates, high fat content, probable increased intake of nitrates and nitrites and nitrates, or nitrosamines, reduced intake of vitamins A, C, and E, and it's thought that the use of aspirin and other non-steroidal anti-inflammatory drugs, the cyclooxygenase 2 inhibitors, may exert a protective effect against colon cancer. That's probable. I don't know whether it's really been proven. When colorectal cancer is found in a young person, like in their 20s, in their teens, then there must be a pre-existing condition such as ulcerative colitis or one of the polyposis syndromes should be suspected. For individuals with hereditary non-polyposis colorectal cancer syndrome, also known as Lynch syndrome, caused by germline mutations of DNA mismatch repair genes, then these individuals are at high risk of developing colorectal cancers at an earlier age than the regular population. And of course, this group of individuals are also at risk of developing other tumors such as cholangiocarcinomas. So it's a cancer syndrome, so to speak. So let's look at the carcinogenesis. I think it's interesting and also important. I think this is an example we use to show a natural sequence of events with an underlying molecular or genetic mishaps, so to speak. So it's thought that there are two pathogenetically distinct pathways for the development of colorectal cancer, and both seem to result from accumulation of multiple mutations. The first one is the APC beta-catenin pathway, and there's chromosomal instability that results in stepwise accumulation of mutations in a series of oncogenes and tumor suppressor genes. Then there's localized colon epithelial proliferation, followed by formation of small adenomas that over time become more dysplastic and ultimately develop into invasive cancers. And this is depicted very well in this diagram borrowed from borrowed from Robbins. So you have a normal mucosa, then a mucosa at risk, and the individual who is at risk, or various risk factors, and the underlying germline inherited somatic acquired mutations are the first hit. Then methylation abnormalities with inactivation of normal alleles become the second hit. Formation of proto-oncogene proto-oncogene mutations, giving rise to adenomas, both villus and tubular adenomas. Of course, the villus adenomas is more at risk. And then homozygous loss of additional cancer suppressor genes, and then ultimately additional mutations. So it's additive, additional mutations lead to gross chromosome alterations, and then you have overt invasive disease. And these are some of the molecular events occurring, mismatch repair genes, and we've already mentioned the APC gene at this point, beta-catenin, KRAS at this point, and various additional suppressor genes such as the P53 and so on. And then you have a critical mass of alterations, and finally you end up with invasive carcinoma. So this adenoma carcinoma sequence appears to account for about 80% of sporadic colorectal. And then the second pathway is a DNA mismatch repair gene pathway, and which accounts for 10 to 15% of all sporadic cases. And this leads to accumulation of mutations, as in the previous pathway, but the involved genes are different. So unlike the adenoma carcinoma sequence, there are no clearly identified morphological correlates. In the DNA mismatch repair gene pathway, the defective DNA repair caused by inactivation of DNA mismatch repair genes is the fundamental and most likely initiating event in colorectal cancers. And there are a number of DNA mismatch repair genes, as we saw in the previous schematic diagram, the MSH2, H6, MLH1, PMS1, and PMS2, which give rise to hereditary non-polyposis colon cancer. And it's thought that the MLH1 gene is the most commonly involved in sporadic colon carcinomas. So those are the two important pathways. In the DNA mismatch repair gene, is thought that microsatellite instability is a molecular signature of the defective DNA mismatch repair. Microsatellite sequences are generally non-coding regions of the genes, so mutations in these genes are probably harmless. But some microsatellite sequences located in the coding or promoter regions of these genes are involved in the regulation of cell growth. So if you remember the cell cycle, there are sequences that are the promoter regions that regulate cell growth, and there are checks and balances at various points, as well as repairs if something goes wrong. And where you have microsatellite sequences located in certain places, and something goes wrong and there is no repair, then you end up with instabilities that lead to mutations that are associated with malignancies. So I think you also probably remember this one, this diagram also from Robbins. The pathways that lead to neoplasia, the two of them, the gatekeeper pathway and the caretaker pathway. In the hereditary non-polyposis coli, mutation of the caretaker gene, such as the remember we said there are several of them, 5 mismatch repair genes. This is one example. Mutation followed by mutation of a second caretaker gene allele, leading to genetic instability or microsatellite instability, mutation of the caretaker gene, and then so it keeps on adding until you have a critical mass of proto-oncogenes leading to neoplasia. The gatekeeper pathway is different, doesn't have the mismatch repair genes, but you still end up in the same place with multiple mutations, excuse me, and involving proto-oncogenes and other tumor suppressor genes. So morphology of the colorectal gene, I think for the carcinogenesis and the molecular basis, you might have to sort of go back and read it by yourself so that it makes sense. Yeah, you generally have to read it a few times to understand the various pathways and the genetic instabilities and mutations. 60 to 70% of colorectal carcinomas, as I think we've already mentioned several times, seen in the rectum, the rectosigmoid, and the sigmoid colon. So the left side of the colon, so to speak, they tend to be annular, encircling lesions, often described as napkin ring. If you think about if you're at dinner and you have the ring that holds a napkin, so they are that sort of encircling annular lesions or napkin ring lesions. And therefore, they present with early symptoms of obstruction. So a patient will complain that they've noted that they have altered bowel movements, whereas they used to be regular, now every other day or once every 3 days, 4 days, and they feel full and they want to pass stool, but it feels as if they are not able to. So the neoplasm starts superficially, slowly invading the deeper layers, and then with ulceration, of course, you end up with rectal bleeding, and eventually you have metastases in various places. So here is a large tumor that is ulcerated, and if you followed this is in the iliocecal region. This is the ilium, iliocecal region, and you have a large tumor here that is sort of rounded, irregular, ulcerated, and bleeding. So right-sided carcinomas tend to grow as polypoid fungating masses. Obstruction is less common than the left-sided tumors. Invasion of the wall and extension to the mesentery, regional lymph nodes, and more distal sites is more common. And mucinous adenocarcinomas, which secrete abundant mucin and that may dissect through the cleavage planes in the wall of the bowel, noted. And small cell undifferentiated carcinomas are rare, and these tend to arise from the neuroendocrine cells in the GI tract. In ulcerative colitis, poorly differentiated infiltrative carcinomas are often seen without an exophytic growth pattern. So here is a tumor, large and ulcerated, and then we start to see some polyps, okay? So that may have been the pre-existing condition that increased the risk, and then maybe one of the polyps underwent malignant transformation. So here is a mucinous adenocarcinoma or mucin-producing carcinomas. You can see these empty spaces filled with mucin, and this is the ribbons of epithelium, malignant epithelial cells that are secreting mucin. So clinical features, they tend to be present for a considerable amount of time before producing symptoms. We've already mentioned that left-sided lesions tend to present earlier because of the obstructive napkin ring pattern, whereas the right-sided have a more infiltrative growth pattern. And these tend to be discovered later, present later clinically, and therefore will have a poorer prognosis because they will have later stage disease. The right-sided lesions tend to present with weakness, malaise, weight loss, unexplained anemia, of course, secondary to long-standing rectal bleeding. Spread can be direct, extension, metastases through lymphatics and blood vessels, and the favored sites for regional lymph node metastases are the liver, lungs, and bones. And the serum levels of carcinoembryonic antigen, or CEA, are related to tumor size and extent of spread. So it's a good measure of burden of disease, and they are also useful in monitoring recurrence of a tumor after resection. Not a good tumor marker because it occurs, it's raised also in inflammatory bowel disease, so you can't use it for diagnosis. But if there is tumor and you measure it, the higher the amount of carcinoembryonic antigen, then it relates with tumor burden. Overall survival rate for colorectal carcinoma is about 35 to 49%. So this means that close to 50% of the patients with colorectal carcinoma will have died by 5 years. Okay. But probably this will be higher in our situation because patients tend to present late, and then the state of our healthcare system is not necessarily great. And of course, it's expensive, so patients will delay, even after the diagnosis, they'll delay in access of care. By the time they do a Harambe and do all sorts of other things, then disease is not waiting for the Harambe to be held. It's progressing. So this is sort of schematic diagram to show staging, which is the clinical process of estimating the burden of disease. Okay, so when you have stage 0 is when you have a mucosal tumor. Stage 1 involve the muscle layer, but not the entire wall. Stage 2, extending to the serosa. Stage 3, extending out to the paracolic tissues on the serosa and omentum. Then, of course, stage 4 disease, there's a distant spread to other organs and transcelomic spread in the rest of the abdomen. Okay. So we are done, I think, with the malignant epithelial tumors or adenocarcinomas. So let's look at other types of tumors. Malignant spindle cell tumors or mesenchymal tumors and lymphomas are the commonest examples in this group. Grossly and microscopically resemble those arising elsewhere in the GI tract. Carcinoid tumors may arise anywhere in the colon and especially the rectum. So the rectum may be the more common site in the GI tract. Squamous cell carcinomas generally limited to the rectal canal, the anorectal region, initially present as plaque-like lesions that later become ulcerated or fungating, and malignant melanomas can occur at the anal verge. So let's look at tumors of the small intestine, 3 to 6%. They comprise 3 to 6% of the GIT neoplasms, slight preponderance to benign tumors. So small intestine, slightly higher chance that they will be benign. Often discovered incidentally, and they include leiomyomas or smooth muscle tumors, adenomas, lipomas. Large lesions, even if they are benign, may cause obstruction, bleeding, intussusception, and volvulus. There may be adenomas, single or multiple polyps, often in the duodenum and ileum, and the risk of malignancy with larger Hamatomatas polyps. Malignant small intestinal tumors, in order of descending order of frequency, carcinoids will be the least common. Adenocarcinomas, lymphomas, and leiomyosarcomas. I actually don't remember seeing a leiomyosarcoma of the small intestine in my many years of practice. But that doesn't mean they don't occur. But certainly carcinoids, adenocarcinomas, and lymphomas we see once in a while. Adenocarcinomas of the small intestine, growth pattern is very similar to those seen in the large intestine. Polypoid fungating ulcerated mass or encycling tumors, the napkin ring type of pattern. A common site is the duodenum, the ampulla ovata. So patient will complain of abdominal pain that is described as cramping, may present with vomiting, and of course weight loss. And generally patients present with late disease, and that's why the 5-year survival rate is the 5-year survival rate is pretty high, 70% after en bloc resection. So if it's resected properly with clear margins, then the 5-year survival rate is pretty high, 70%, despite late presentation. So let's look at carcinoid tumors. These are tumors that arise from the endocrine cells of Kulczycki or enterochromaffin cells found along the length of the GI mucosa. And the cells have an affinity for silver salts. So we use these silver-based stains pretty often in diagnosis. 60 to 80% occur in the appendix and terminal ileum, 10 to 20% in the rectum, and the remainder in other places, stomach, duodenum, and esophagus. Other locations of carcinoid tumors include lungs, pancreas, biliary tract, ovaries, and liver, but these are less common. The peak age, 6th decade, so people in their 50s, yes, 6th decade, comprise 2% of colorectal carcinoma and 50% of small intestinal carcinoma, and tumors in the appendix and rectum generally spread locally and rarely metastasize. The ileogastric and colonic carcinoids are frequently malignant. Remember, carcinoids can be benign, of intermediate malignant potential, or overtly malignant. So when they occur in the ileum, gastric, and colon, then they are frequently malignant. Here's some morphologic examples of carcinoid tumor in the ileocecal region, where we say it is the most common site, and around the appendix, okay, round fungating mass. The morphology is pretty uniform cells, neurosecretory cells, often occurring in nests or sheets, and electron microscopy is very classic. You have these neurosecretory electron-dense bodies in the cytoplasm, evidence of their differentiation as neurosecretory cells. So they are round submucosal elevations, bright yellow or yellow-gray in color. Here in this photomicrograph, they are bright yellow, maybe deeply infiltrative, and penetrate the muscle to the serosa. By the time they are discovered in the gastric and ileo sites, they tend to be multiple. And the tumor cells are arranged in trabecular, insular, glandular, or undifferentiated patterns, and that this monotonous appearance of small, regular, round nuclei. Clinical features of carcinoid tumors, they may be totally asymptomatic, or they may cause obstruction, intersusception, bleeding with chronic anemia, or anemia of chronic blood loss. And if they are secretory, they may be associated with Cushing's carcinoid and other syndromes. 5-year survival rate is pretty high, 90%. But if there are liver metastases, then this may drop to 50%. So it's really dependent on stage of the disease. So carcinoid tumors may present with carcinoid syndrome if they are secretory. And the syndrome occurs in about 1% of all patients with carcinoid, so it's not uniform. And in 20% of those with widespread metastases. And this may take the form of paroxysmal flushing, excuse me. Episodes of asthma-like wheezing, right-sided heart failure, attacks of watery diarrhea, abdominal pain, edema, pellagra-like lesions in the skin and oral mucosa. And these are all due to the chemical mediator serotonin, or 5-hydroxytryptamine, 5-HT, which is decarboxylated in the liver and lungs to 5-HIAA, 5-hydroxyindole acetic acid. And in fact, for diagnosis, chemical diagnosis, this is what we measure. And the syndrome is classically associated with ileocarcinoids more often, especially when there is hepatic metastases. So remember that not all carcinoid tumors are associated with carcinoid syndrome, only if the tumor is secretory of serotonin. Lymphomas of the small bowel. So remember, the gut has probably one of the largest amount of lymphoid tissue other than lymph nodes. So up to 40% of lymphomas will arise in the gut. 1 to 4% of all GIT malignancies are lymphomas, so they're an important category, up to 4%. Primary GI lymphomas exhibit no evidence of liver, spleen, or bone marrow involvement at the time of diagnosis, but of course, as the disease advances, then this may change. Sporadic lymphomas arising from B cells of the mucosa-associated lymphoid tissue, or MALT, is the common form. Usually affects adults, lacks a sex predilection, so male to female ratio is 1:1, and they may arise anywhere in the gut, stomach up to 60%, small intestine up to 30%, colon up to 15%, and distal colon 10%. So majority will occur in the stomach. And you remember there is an association with H. pylori infection. The gastric mold arise in the setting of mucosal lymphoid activation, and here it is as a result of Helicobacter-associated chronic gastritis. Celiac disease is associated with a higher than normal risk of T-cell lymphomas. And in the small intestine, they tend to have lymphomas tend to have a better prognosis than those that arise in other sites. And treatment for these lymphomas is generally combined surgery, chemotherapy, and radiation. Just to wrap up, I'm actually surprised that I've taken such a short time. I thought we'd be here for at least an hour and a half. The small intestines are named for their diameter, not their length. It's just some chit chat. The small intestine is up to 7 meters in length and only 2.5 centimeters in diameter, whereas the large intestine is only 1.5 meters in length, but 7.6 centimeters widest diameter. So I think that's the end. Any questions? I know it's a bit of a mouthful, and you may need to sort of go home and read and think about a lot of what I have mentioned. Let me see whether I can see the chat. I don't see any questions or comments in the chat. Anybody with a question? Come, you are everybody's representative.
Yes, Professor. There is one question in the chat box. What is expected? Yes, when the examiner asks about prognosis of carcinoma.
Prognosis is the other word for prognosis, I think, is outcome, clinical outcome. Did somebody ask you about the prognosis? It's really dependent on stage of disease, isn't it? If you have just a small 3 millimeter size mucosal lesion compared to somebody who has an obstructive lesion and metastasis or stage 4 disease, then the clinical outcome for those two patients will be vastly different, isn't it? Yeah. So
yes,
it's dependent on stage of disease. So first you have to understand what the word prognosis means. Yeah.
Yes.
Yeah.
Then there's another one. Is Gardner syndrome a progression of APC?
Gardner syndrome is one of the Polyposis coli syndromes, yes, but it has a different pathway. It's one of the ones with mismatch repair genes. Yeah, so it's a different pathway. Remember, we said one is the APC gene, beta-catenin pathway, and the other one is the mismatch repair genes. And the Gardner syndrome and the non-hereditary Polyposis coli tend to be the problem is the mismatch, the DNA mismatch repair genes. Maybe I can go back to, maybe I can go back to that. So here, this is a question now, the answer to the prognosis, yeah? If you have a patient with stage 0 or stage 1 disease where you just have mucosal and submucosal lesion, compared to somebody who has a large tumor with metastasis, then this patient with stage 4 disease will have a poorer outcome. Yeah.
Yes.
Than somebody with stage 1 or stage 0 disease. Okay, let me go to the mismatch repair gene slide. Okay, I think it's this is the first pathway, and then the next one is the DNA mismatch repair genes gene pathway. Okay, and the Gardner syndrome. Where was it? Yeah, here we are. So the Gardner syndrome, which is also a part of the syndrome, is Polyposis coli, familial Polyposis coli, and Charcot syndrome. They have an autosomal dominant gene, and they tend to be, I think their problem is the mismatch repair genes, not the APC gene. Okay. Hope that answers your question. Any other question?
Yes, there's another one. Please, if you could go over the explanation for ulcerated carcinomas under the colorectal carcinoma section.
Ulceration, it just means the surface of the tumor is ulcerated. That's it. Yeah.
Okay. Yeah.
It's just the appearance. It's just the morphology of the tumor. You have a round tumor. It begins as a round with an intact mucosa. Then, of course, as it grows, the surface mucosa breaks out and ulcerates, and then it bleeds. Yes. So it's just the morphology. That's just the morphology. Dietary recommendations that prevent people from getting intestinal carcinomas. High fiber diet, yes. Low refined carbohydrates. Generally make sure the vitamins A, C, and E are part of the diet, or diets that are high in vitamins A, C, and E. And generally those are fruits, lots of fruits and vegetables, and less refined foods and fats. Yeah, that's it really. And it's been shown that diets that reduce or improve inflammatory bowel syndrome also are good for preventing colorectal carcinoma, because they are related. Yeah.
Right. Yes. I wanted to ask, how does nitrates act as a risk factor for the carcinoma?
You've forgotten the chemical and physical carcinogens. Remember that lecture in third year?
Yeah.
Yes. Nitrosamines, nitrites, and nitrates are part of the big group that increase the risk for GI and urinary tract cancers. Yeah.
Okay. Yeah. Right.
Mm.
Okay. I understand. Thank you. Thank you, Professor.
Any other question? That's
I don't think so. Yes. Think
okay. All right, good. I think the
If there are
basic
any more,
book. Yeah, if there are any more, you can write me an email.
Email, please.
Basic Pathology by Robbins is a good chapter to read. Then, of course, there are lots of internet sources, but the book that I recommend for you is Robbins' Basic Pathology. Not the big book, the smaller book. The big book is, unless you want to become a pathologist in year 4. So Robbins' Basic Pathology is the recommended reading textbook. Yes? Okay.
Yes.
Sawa, have a good afternoon then.
You too.
Okay, all right.
You too, Professor.
Okay. All right.